cost of this innovative technique. The number one, we have replaced the trocar protective sleeve of a special instrument set with the trocar and protective sleeve of PFN-A2 set, which is present in our OT. And number two, we have eliminated the jig portion of the special instrument set and did both proximal as well as distal locking while freehand technique. And number three, we have added a color-coded tibial nail extractor or more improved version of the color-coded tibial nail extractor for RCT nail introducer compositioner to introduce the nail inside the intramedullary canal in proper position. So these three changes makes this innovative technique as a very, very cost-effective way of doing suprapatellar nailing of tibia. So friends, this is not a Jogaru technique. This has very strong mathematical or scientific basis. After jumping so many steps of mathematical equation, we have come to know that the success of interlocking nailing is equal to K into C into P into Z. Whereas K is the expertise in the art of the freehand technique of locking, whereas the C, P and Z are the respectively the availability of the C arm in your OT and protective sleeve in your special instrument set and jig in your special instrument set. If you increase the value of K to such an extent that the Z becomes zero, that is dependence on the jig becomes zero, this creates a scenario where the surgeon has mastered the freehand technique of locking and can perform both proximal as well as distal locking without the jig. So this is the mathematical basis. So we conducted a study between March 20 to March 22-5 on 100 cases of non-articular fracture of the tibia done by Dr. Thakur innovative technique of suprapatellar nailing of tibia. So along with the other instruments, we had two pilot instruments. Number one, a color-coded tibial nail extractor, which is present in intrapatellar nailing set, and a more improved version of the color-coded tibial nail extractor called RCT nail introducer compositioner to introduce the nail. This is the skin incision, you can see the transverse incision but you can give vertical incision also. And this is the innovative part of this innovative. Second picture shows the innovative part of this innovative technique, the introduction of the trocar and protective sleeve from PFN-A2 set inside the retropatellar space. And the third picture shows the innovative part of this innovative technique, that is the proximal locking by freehand technique. So after making a hole just medial to the lateral tibial spine, we introduce a malleable guide wire. After percutaneous reduction of the fracture with the percutaneous forceps and after serial leading, we mounted a appropriate side nail over the color-coded tibial nail extractor or RCT nail, introduced compositioner, and finally we introduced the proximal as well as distal locking by freehand technique. So this is the flow diagram, nothing to repeat it again, and this is the post-operative follow-up steps. Again, you all are aware of this. It is same as the intrapatellar nailing of tibia. No patient complained of knee pain in our series. All patients gained full range of movement in our series by 16 weeks. And final follow-up, 84 cases found excellent results, whereas 30 had good results, whereas 2 had subacute infection at the screw site and 1 had infected non-union. The average time of union was 80 plus minus 10 minutes, whereas average fluoroscopy time was 38.5 plus minus 6.5 seconds. All patients followed 2, 3, 6, 8 and 12 weeks, and the average time of the union was 8 weeks post-surgery, whereas complete union occurred by 12 weeks in all our cases. These are the few cases, clinical and radiological pictures of the few cases done by Dr. Thakur innovative technique of suprapatellar nailing of tibia. So the number of studies done on this innovative technique is small. I think this is the only study done by me, although good number of patients were included. The study was not comparative with the standard technique, so a status of cartilage over the patella and the trochlea was not evaluated in this study. Those furthermore studies required to compare this innovative technique. We had a high-tech presentation in IOACON and found a space in International Journal of Orthopedic Sciences. You can see, and this is a video we don't have time to show you. So the take-home message is this technique would prove a boon for small and medium-class hospitals situated in BSC Great Town in India and poor countries like Bhutan, Nepal and Bangladesh, where the allocation towards the health is very, very low. So this could prove also a very useful technique for Ayushman Bharat Yojana, which is the dream project of our Prime Minister, Sri Narendra Modi. Thank you very much for patient hearing. Thank you. The traditional teaching that the 99.99% of these cases unites without any significant deformity and without any significant functional impairment. But later on, it was found that there are severely displaced fractures, severely comminuted fractures. About 15% of cases require surgical treatment either in the form of tense nailing or the internal open reduction and internal fixation with plating. So let us come to our main topic, that is tense nailing is unlike conservative management. It provides stable fixation and early mobilization and reduces the risk of non-union and malunion. Tense is less invasive, resulting in a smaller incision, reduced soft tissue damage and fewer potential complications, making it an attractive option for managing displaced fracture of the clavicle. So we conducted a study between March 2022 to March 2025 on 25 cases of clavicle fracture, mid-third fracture, all were simple displaced fracture according to AO classification 15D1 and 15D2. The age of the patient was 16 to 48 years. No comorbidity was found in our study group. So all patients treated by titanium elastic nailing in my hospital. So the mode of trauma, road traffic accident was the main mode of the trauma, whereas fall from height and fall on out the step side was the other mode of the trauma. So these are the typical mode of injury, the fall on the shoulder to protect the head injury in the road traffic accident. This picture is taken from AI, and this is the typical clinical presentation. A bump at the site of the fracture and the skin appears as if the fragment will penetrate the skin. And this is the radiological typical presentation, more than 2.5 centimeter displacement. And the jet type of cognition are the radiological indication for the surgical treatment, either in the form of tense or internal fixation with the plate and a screw. So these are the already explained. The simple fracture were taken into consideration. Displaced simple fractures are spiral or oblique or transverse or short oblique, 15D1 and D2. The patient lies supine on a affected lip, elevated, and the arm are hanging outside the table, so that we can facilitate the abduction and external rotation at the shoulder to facilitate the reduction of the fracture by closed lip. The incision, a small incision and a transverse or longitudinal incision about 1 to 1.5 centimeters, just lateral to the sternoclavicular joint is given, adductor making an incision, make a hole with the help of drill bit, and then we make this hole continuous with the intramedullary canal of the clavicle. But this is very, very crucial step. One should take his own time and use tips and tricks to do this step, because the heart and lung, like vital structures, are waiting for an instrument to escape. So after making the hole, we did tense nailing after close reduction or mini incision reduction. So the immediate post of pain management and immobilization, at the 2 weeks we did suture removal, at 6 weeks radiographic assessment of the fracture area, and 12 weeks the functional assessment, and if required the implant removal was done. And the operative time was 30 to 60 minutes, whereas fluoroscopic time was 10 to 30 seconds, and the blood loss was 20 to 50 ml in all our cases. So the excellent result in 76% of cases, whereas 16% cases were good results, and fair and poor results were 4% each in our study group. The complications are nail bypass, superficial infection, and the malunion, each were 4%, whereas hardware irritation was 8% in our study group. And these are the few cases. You can see that 15B1 fracture treated by titanium elastic nailing, beautiful surgery without use of any instrument. The reduction has been done only by shoulder movement, external rotation and abduction, and with the help of the thumb and index finger. The beautiful surgery And this is another case, yet another case of 15B1 fracture treated by titanium elastic nailing, yet another case of 15B1 fracture treated by titanium elastic nailing. These are the 15B2 fracture, this is 15B3 fracture treated by titanium elastic nailing. Ideally, it should be treated by open reduction and internal fixation, but we did tense nailing, and you can see the 6-month follow-up, the beautiful radiological union. And this is the functional result. You can see so the time is less. So the limitation of this surgery is a small number of cases included in this case, in this study. So the short follow-up period and retrospective design. So a study with large number of population and long duration of follow-up and prospective study is required to establish this modality of treatment as an attractive option for the treatment of displaced fracture of the take-home message is tense nailing is effective for the clinical fracture with good to excellent outcomes, minimum complication if the patient are selected properly and the technique is performed properly. The further study are needed to confirm the long-term efficacy of this. This work published in International Journal of Orthopedic Science. 17 years old man, the road traffic accident was the mechanism of injury, clinical presentation, severe pain and deformity, and I believe to bear the weight on the right side, whereas the left side he had a Gallagher fracture. So the challenge was the patient presented with significant surgical burden and the major long bone fracture concurrent with the complex forearm fracture and dislocation, which we called the Gallagher fracture and dislocation. And this is the X-ray of the femur, the shaft femur, mid-third fracture, a 17-year-old gentleman, and the forearm Gallagher fracture, severely displaced fracture. Inner canal, it was narrow, so the nailing was difficult. The standard treatment is nailing, and ideal treatment for this Gallagher fracture is the plating. But I opted nailing, although it was difficult nailing in the both fracture and the slight distraction, the tense nailing for Gallagher fracture, and this is not reported in any literature.
for such a severely displaced fracture, the tense nailing should be considered. In fact, there is no literature present for the tense nailing for this type of Gallagher fracture. So we did for the minimally, because it is minimally invasive, and periosteal and endosteal blood supply are maintained in both fracture, and the interlocking nailing was done in the sharp femur, and only 9 millimeter nail could be negotiated because the narrow medullary canal. So there is slight distraction, as you can see in this picture, but we did locking. It was difficult nailing. So the goal was to provide sufficient stability for early mobilization despite of an anatomical constraint, and implant was 9 millimeter nail, and technique was minimally invasive. And whereas in this left radius, the Gallagher fracture, we did tense nailing. In this case also, the 2 millimeter tense nail was used. Usually you use a 2.5 millimeter tense nail, but we use 2 millimeter tense nail. Still there is distraction at the fracture site. So this was the problem with this due to the narrow canal. But this is the 6-month follow-up. You can see I sent this X-ray in Indian Orthopedic Research Group, IORG, and they told to revise this case, bone grafting and plating for Gallagher fracture. So, but I left it and wait for, this is the 8-month follow-up. Still there was better union than 6 months, but this was not hypertrophic, and this is 11 month. You can see. So after waiting 11 months, the union is complete in both the fracture. The secondary colors have been formed. It was not hypertrophic non-union. It was the union, secondary union was taking place, although it was delayed union. But this is the functional result. You can see that supination, pronation, and wrist movement, flexion and extension all are present. And the tense nailing is provides sufficient stability for secondary union even in length critical fractures, because the narrow canal and the length should be maintained to, and DR, UJ should be reduced properly. We followed the throughout the 11 months for this maintenance of the length and DR maintenance. And advantages of this minimally invasive approach for Gallagher fracture and femur is minimally invasive and reduce operative time and significantly minimize minimum blood loss. And this is the conclusion that the TENS is viable, effective alternative for plating for the complex forearm injury. The successful management of this double fractures case confirms that interlocking nailing of femur and TENS aids higher union rates and excellent functional outcomes. This approach should be considered for Gallagher fracture in adult after further studies, because I think this is the first case in severe Gallagher fracture. I did TENS. So this case was published in International Journal of Orthopedic Sciences.
सिस्टर बीना का मैसेज आया है, अर्जेंट लिखा है, मेरे बच्चे के ट्रीटमेंट के लिए 1 लाख रुपए चाहिए डॉक्टर, तुरंत भेज दीजिए प्लीज।
सिस्टर बीना, मैं पहले सिस्टर बीना को फोन करके पूछूंगी, फिर भेजूंगी, क्योंकि मैं मूर्ख नहीं हूँ।
वेल डन डॉक्टर। यूपीआई कहता है अगर पहचान के व्यक्ति से भी ऐसे मैसेज आए तो हो सकता है कि उनके मैसेजिंग ऐप हैक्ड हो। तो पहले नॉर्मल कॉल करके चेक करो और कहो मैं मूर्ख नहीं हूँ। जाइए, आप भी किसी का टेस्ट लीजिए।
थोड़ा सा पाउडर और झाग ढेर सारा, भर भर के कपड़ों को पल में निखारा।
तुझे भी तो खुद को बस थोड़ा लगाना है, तुझे भी तो खुद को बस थोड़ा जगाना है। खुद के वादों से ही तो जन्मा है, तुझसा ही निर्मा है, तुझसा ही निर्मा है। जिद्दी दागों के लिए निर्मा एडवांस
provides stable fixation and earlier mobilization and reduces the risk of non-union and malunion. Hence, is less invasive, resulting in smaller incision. After the study between March 2020 to March 2025, on 25 cases of the displaced fracture of the clavicle, the age of the patient was 16 to 48 years, and no comorbidity was found in our study group. All patients treated with titanium elastic nerve. So the road traffic accident was the main mode of the trauma, whereas the fall from height and the fall on the outstretched hand was the other mode of the trauma. So the typical mode of the trauma, this picture is taken from the AI, and this is the fall on the shoulder to protect the head injury in mode of trauma. And this is the typical presentation, a bump at the fracture site, and the skin appears as if the skin will penetrate the fragment will penetrate the skin. So, and this is the typical radiological picture. You can see the severely displaced fracture, more than 2.5 centimeter, a jet type of fracture, that type of comminuted fracture, and the other indication for surgical treatment is the floating shoulder. So these are the typical presentation as well as the radiological presentation and the mode of the injury. And we included the simple fracture only, 15B1 and 15B2 according to AO classification. 15B1 is a spiral and oblique, whereas 15B2 is a transverse and short fracture. So the patient lies supine with affected limb elevated and hanging outside the table so that the reduction can be done by doing abduction and external rotation of the shoulder. So incision, is 1.5 centimeter lateral to the sternoclavicular joint, and after making incision, we make a hole with the help of the drill bit or the bone out. But this is a crucial step. One should be very, very cautious because the heart and the lungs are like vital structures are waiting for your instruments to escape. So this is a very crucial step, and then make this hole continuous with the intramedullary canal of the clavicle, and then we did close reduction or mini incision reduction, and then titanium elastic nailing was done after reduction of the fracture. So the post-op protocol or immediate post-op, we did pain management and immobilization of the limb at the 2 weeks, the wound inspection and the suture removal at the 6 weeks, the radiological follow-up for the fracture healing, and by 12 weeks, the functional assessment of the fracture healing, and finally, if required, the implant was removed at the 12 weeks. The 6 month final follow-up was 20 to 50 ml in all our cases. So the post-operative observation, excellent results, 76% of patients, whereas the good results were found in 16% of cases, whereas the 4% was the figure for the fair as well as the poor results. So the complications, the nail bite count, superficial infection, and malunion each had 4% figure, and the hardware irritation was 8% in all our cases. These are few cases. The radiological as well as clinical picture, as you can see, this is 15B1 fracture, treated by titanium elastic nail, the post-operative case, and the beautiful surgery has been done. You can see the one stitch surgery, no instrument was used to reduce the fracture, only the thumb and the index finger was used to reduce the fracture, and abduction and external rotation of the shoulder was used to reduce the fracture. But this does not happen always. Many times we require the mini open reduction of the fracture. So this is another case we did the 15B1 fracture and treated by titanium elastic welding. You can see the 6-month follow-up, the beautiful union, the secondary union. There are 2 bumps in the clinical picture. You can see at the fracture site there is secondary callus formation. 1 bump is due to secondary callus formation, and other at the entry site you can see that there is hardware prominence. So this is another case of the mid-third fracture treated by titanium elastic nailing. Yet another case 15B1 fracture treated by titanium elastic nailing. Yet another case of 15B2 fracture treated by titanium elastic nailing. And this is again 15B2 fracture treated by titanium elastic nailing. And this is 15B3 fracture. Ideally, it should be treated open reduction and internal fixation with the plate and screw. But we did titanium elastic nailing in this case also, and you can see that the beautiful union of the fractures at the 6-month follow-up period. So this is the functional result. And the limitation of this surgery, a number of cases included in this study was small and the short period of follow-up, and this is the retrospective duration, and a prospective study is required to establish this treatment as the attractive modality of the treatment for the mid-third fracture of the clavicle. So the take-home message is TENS nailing is effective for the clavicle fracture with good to excellent results, the minimum complication with properly selected patient and properly technique performed. So the further studies are needed to confirm the long-term efficacy of this modality of treatment. So thank you very much for your patience here.
बवाल।
ब्रो बवाल। 5 मिनट ब्रो बवाल। 5 मिनट।
ये फ्रैक्चर है टिबिया का, कई भागों में विभक्त है और इसे डॉक्टर ठाकुर इनोवेटिव टेक्निक ऑफ सुप्रापेटलर और रिम करने के बाद किया जाएगा। के स्क्रू को अपर फ्रैगमेंट का स्क्रू है। ये RCT नेल इंट्रोड्यूसर कंपोजिशनर के द्वारा डाला।
Hello friends, today I am going to give a demo. I am examining the fracture in reduced position and I am confirming size of the nail. Hello friends, I am Dr. R. In the nail, pressing the spiral blade by clockwise movement and removing the screwdriver by anti-clockwise movement. So the spiral blade, the first put being done now. Post-operative for unstable type of interorthopaedic fracture, we can make this patient mobile from second post-operative day, which is usually required. Although this was not a very displaced fracture, but to make the patient mobile, we planned this surgery for this patient. Thank you everybody. Hello friends. 12 days after I started working, and distal are done with free hand technique. But this can be lessened by gaining more and more experience in free hand technique for locking proximal and distal tibia. Thank you. The number one myth is interlocking nailing of humerus will severely impair the shoulder function due to rotator cuff damage. The reality is, with proper technique and entry point, the rotator cuff damage can be minimized and shoulder function can be preserved. So the myth number 2 is there is always chance of radial nerve injury as it is a complication for the interlocking nailing of humerus, and it is not a complication for the open reduction and internal fixation for plating. So it is, yes, it is, there is risk of radial nerve injury when the fracture is at the spiral root. There is chance of the radial nerve injury, but in the rest of the part, if the fracture is in the rest of the part of the humerus, there is minimum chance of the radial nerve injury when the instruments like the guide wire, remote, and the nail is introduced after proper reduction of the fracture in the distal fragment. Both AP and lateral view, the fracture is reduced properly. Only then these instruments are introduced inside the distal fragment. And don't allow your instrument to wander inside the soft tissue. So these are the two myths which is associated with interlocking nailing of humerus, and other two controversies, whether which position of the patient should be used for
the interlocking nailing of humerus. There are three positions. Number one, supine position. When it is used, it is comfortable for the anesthesia point of view as well as the surgeons. But the distal locking, which is done by freehand technique, is slightly difficult and tricky because the anterior surface of the distal part of the humerus is triangular. So finding the entry point for the distal locking is slightly difficult because slipping of the drill bit or KY. So it should be at angle, it should be introduced at angle, and then it should be kept in a straight line. So this is the disadvantage of supine position, and in lateral position as well as the prone position, the distal locking is done from the posterior surface, which is flat. So the entry hole, finding the entry point for the distal locking is easy because the surface is the flat, but it is uncomfortable position for anesthesia point of view, and the surgeons it depends on the surgeon's choice. So I do use supine position for all my interlocking nailing. Number three controversy is because it is non-weight bearing bone. So one screw distal and one screw proximal is sufficient. But I use 2 screw distal and 2 screw proximal because the 2 is always better than 1, always stronger than 1. If it is just like the 2 kidney present in human body, if one fails, other start working. So, and 2 engines in the aeroplane, one engine fails, the other start working automatically. So, if one screw is not working, then the other screw will do its work. So the fixation is better by 2 screw proximal and 2 screw distal. So friends, these are the advantages of locking nailing over the plating of the humerus, and these are the myths and these are the controversies whether 2 screws should be put proximal as well as the distal, what position should be used in this talk, and let us get tuned for the next video and subscribe my channel for more update on orthopedic surgery and insight.
नॉर्मल डिलीवरी होनी थी पर इमरजेंसी सी सेक्शन करना पड़ा। 25,000 रुपए की जगह 1,20,000 रुपए का बिल आ गया। ऊपर से बेटी हुई तो सास ने सुनाया। इस करमजली ने हम पे और बोझ बढ़ा दिया। मेरा नाम करिश्मा है, मुरादाबाद से। 9 महीने इंतजार के बाद जब लेबर पेन शुरू हुए सब एक्साइटेड थे, पर हॉस्पिटल पहुंचते ही डॉक्टर ने बोला बेबी की हार्ट बीट ड्रॉप हो रही है, नॉर्मल डिलीवरी रिस्की है, तुरंत सी सेक्शन करना पड़ेगा। 25,000 रुपए का बजट था, पर ऑपरेशन, एक्स्ट्रा मेडिसिन, 5 दिन हॉस्पिटल स्टे, बिल 1,20,000 रुपए बन गया। पति ने अपने भाई से लोन लिया, पापा ने अपनी एफडी तोड़ी, सब टेंशन में थे। फिर जब बेटी को देखा दिल गार्डन गार्डन हो गया, पर घर आते ही सास का चेहरा देखा। कुछ कहती नहीं थी पर नजर से सब समझ आ रहा था। तीसरे दिन उसने बोल दिया इतना खर्चा करवाया, लोन लिया, सब परेशान किया, और है भी तो लड़की। इस कर्मजली ने हम पे और बोझ बढ़ा दिया। वो अल्फाज सुन के अंदर से टूट गई। पति ने कुछ नहीं बोला, सब चुप थे। मैं बेटी को गोदी में लिए बैठी थी और सोच रही थी क्या सच में ये बोझ है? क्या सच में मैंने गलत किया जो लड़की पैदा हुई? रात को जब बेटी सो गई।
ये है मिस्टर प्रशांत कुमार जो असम से आए हैं। उनके दाहिने कूल्हे का एक्सरे पिक्चर जैसा कि आप देख सकते हैं काफ़ी डिफॉर्म्ड हो गया है और एक हो रहा था रखना है। उसके बाद जिसमें कूल्हा को बदला गया है उसको और लो चेयर पर भी आराम से बैठ जा रहे हैं।
छपरा के डॉक्टर आरसी ठाकुर ने हड्डी फ्रैक्चर के इलाज में क्रांतिकारी तकनीक विकसित कर देश भर में पहचान बनाई है। उनकी तकनीक से 35 लाख रुपए तक का महंगा इलाज मात्र 35,000 में संभव हो सका है। ऑर्थो सर्जरी में योगदान के लिए गुवाहाटी में आयोजित इंडियन ऑर्थोपेडिक एसोसिएशन के राष्ट्रीय सम्मेलन में उन्हें इनोवेशन अवार्ड से सम्मानित किया गया। यह उपलब्धि छपरा, सारण और बिहार के लिए गर्व की बात है।
इनोवेशन अवार्ड इंडियन ऑर्थोपेडिक एसोसिएशन द्वारा शुरू किया गया है, जो कि गुवाहाटी IOACON 25 में दिया गया है। और यह अवार्ड पूरा भारतवर्ष में 3 ऑर्थोपेडिक सर्जन को मिला है, जिसमें बिहार से मेरा ही नाम है। अतः इससे छपरा जिला में जिला का कोई ऑर्थोपेडिक सर्जन या बिहार का कोई ऑर्थोपेडिक सर्जन को पहले बार सौभाग्य प्राप्त हुआ है जिसमें मेरा नाम आया है।